Pneumonia. Pneumonia is serious infection in one or both lungs. Bacteria can cause inflammation in the air route, filling lung with fluids or pus, making it difficult to breathe. Respiratory symptoms of pneumonia are cough, fast breathing, dyspnea, which is shortness of breath, wheezing sound, chest pain, increased sputum production. The systematic symptoms of pneumonia are fever, chills, fatigue, tachycardia, diarrhea, nausea and vomiting, confusion, and hypotension. Note, systolic blood pressure under 90 is warning sign. Let's look at pneumonia pathogens. First, Streptococcus pneumonia. This is gram-positive bacteria, and this is the most common pathogen, also the member of normal flora for many people. Transmission through air droplet, for example, coughing, sneezing from infected person. The others are all atypical bacteria. Second, Mycoplasma pneumonia, Chlamydia pneumonia, Legionella pneumophilia. So, Streptococcus pneumonia is the only gram-positive and all the others are atypical, and they are atypical pathogens because they are not identified by gram strain. So these were pathogens. Let's check about the drugs, the antibiotics. So antibiotics usually work for 5 days to 7 days. The result should be better when in those days. So for the drug for mild to moderate pneumonia, we have penicillin for the first line. Ampicillin and amoxicillin is the first line, and for people who have a penicillin allergy, we use ceftriaxone or cefotaxime plus doxycycline or clarithromycin. Third line is azithromycin, clarithromycin, or moxifloxacin. Moxifloxacin is the only one that is used in quinolones. So amoxicillin and ampicillins are first line for mild to severe community-acquired pneumonia. Amoxicillin treats both gram-positive bacteria and gram-minus bacteria. We use amoxicillin 1 gram 3 times a day instead of 500 milligram. Why? This is because we want the higher plasma concentration. Since as pneumonia has high MIC, we need to the drug should be above the MIC. So it is preferred over other penicillins because it has superior oral viability and treats H. influenza bacteria, which is gram-minus. Amoxicillin is recommended better than amoxicillin plus clavulanate combination in treating because it has narrow spectrum. Also, the most common type of pneumonia is Streptococcus pneumonia, and it does not produce beta-lactamase. So when we are mixing, we decrease amoxicillin, but we still need 1 gram 3 times a day. So this is why we don't use combination, but just amoxicillin, because we want 1 gram. So note penicillin G, in other words, benzyl penicillin. This is IV for empirical treatment of moderate community-acquired pneumonia. Combination with doxycycline or clarithromycin would provide therapy for atypical bacteria. Penicillin G is reserved for children who oral amoxicillin is not working. Benzyl penicillin and amoxicillin dose should be adjusted if the patient has renal impairment. And how do we know the renal impairment? We do by GFR, and glomerular filtration rate can be categorized into few categories. So normal people has clearance over 50, 31 to 50, 10 to 30, and less than 10 milliliter per minute, the GFR. So second, let's look at cefuroxime. So cefuroxime oral, ceftriaxone IV, cefotaxime IV are the ones that is used for community-acquired pneumonia. So cephalosporins are reserved for patients with non-severe penicillin allergy. So cefuroxime oral has superior antipneumococcal activity than other cephalosporins. Note, we do not use cephalexin in pneumonia because it does not treat H. influenza. H. influenza plays a big role in pneumonia. We have IV for ceftriaxone and cefotaxime. So, yeah, it is more likely to cause harm to normal flora. We do not prescribe ceftriaxone for all the hospitalized patients because it has broad spectrum and it can lead to antibiotic resistance. Also, this may affect GI flora and cause C. diff infection or candida infection. So this is broad spectrum. Second line, doxycycline. It is protein synthesis inhibitor. So first line is always amoxicillin, but if it does not work or patient has penicillin hypersensitivity, then use doxycycline as an alternative. Note, doxycycline plus benzylpenicillin combination also treats atypical bacteria. Third line are azithromycin and clarithromycin. These are also protein synthesis inhibitor. Third line treatment if second line doxycycline doesn't work. Azithromycin is oral and clarithromycin is IV. It has broad spectrum and beware, azithromycin resistance is increasing in community. So third line, moxifloxacin is part of quinolone. This is bactericidal. It works by inhibiting DNA synthesis by blocking bacterial DNA cachease and topoisomerase 4. Only moxifloxacin is used for pneumonia out of all the other quinolones since they have a broad spectrum. Moxifloxacin is not the first line because of quinolone resistance and C. diff risk. It has better anti-pneumococcal activity than ciprofloxacin. This is why we only use moxifloxacin in community. Process when patient is becoming better. For example, fever has been managed, blood pressure was too low before but now it's okay. We switch from intravenous to oral. For example, ceftriaxone IV is changing to cefuroxime 500 mg oral or amoxicillin 1 gram oral. Note there's a drug interaction, so calcium IV fluid should not be used with ceftriaxone. There's a chelation problem with doxycycline. There's CYP3A4 substrate problem or QT prolongation problem with clarithromycin. So note that there's drug interaction.